Welcome to Breaking Barriers, Expanding Health Equity Through Games and XR. I'm Allison Sekuler. I am the President and Chief Scientist of the Baycrest Academy for Research and Education at the Baycrest Center for Geriatric Care, as well as the President and Chief Scientist at the Center for Aging and Brain Health Innovation. I'm also the Sandra Rotman Chair in Cognitive Neuroscience and a professor at the University of Toronto and at McMaster University. And I'm so happy to have everyone here today. We've got a terrific set of guests, panelists who are going to be joining in on this conversation. We've got among the panelists, we have Cassandra Walker. Welcome, Cassandra.
Nice to be here.
We've got Dr. Sarah Adler. Welcome, Sarah.
Thank you. Thanks for having me.
And we've got Dr. Olu Ajilore.
Thanks for having me.
Great to have you all here. Now, one of the things that's really interesting as we're coming out of the pandemic is that, from my perspective, the pandemic did a couple of different things. On the very negative side, obviously, one of the things that it did was it really highlighted the health inequities in our healthcare systems. I'm in Canada, you're all in the United States, but in both of those cases and around the world, what we saw was that different groups of individuals fared differently through the pandemic, and it really shined the light on some systemic issues in terms of health inequities in all of our systems. On the other hand, one of the positive things that has come out of the pandemic, if you can say that, is that there's been a move toward adopting new kinds of technologies that already was in place, a movement toward that before the pandemic, but the pandemic actually really sped the creation and adoption of some of those technologies. So, for example, in my organization, CABI and Baycrest, we worked with the Ontario government to create a program called LIFA, which is a gamified virtual training program for nurses and personal support workers in long-term care, because it was hard to be hiring people and training everybody, upskilling people to have enough folks to take care of the people living in long-term care, for example. That sped through much, much faster, and it's been hugely popular, and it's done a great job in training. And we've also seen within the field of not just games, but also in the field of AR, VR, XR, et cetera, a lot of uptake. So, for example, especially in my field of aging, I know a lot of really good examples of again, companies that were already out there, but they've really started to gain more traction through the pandemic because people were looking for these kinds of solutions. So, companies like Embodied Labs and MindVR, React Neuro, Mindful Gardens, and so many more. But I know that each of you also is coming from a different sort of sector. So my sector is obviously aging and brain health, but people are coming at this from different perspectives, as well as working with different sectors. So what I'd like to do is ask each of you in turn. I'll do a little brief introduction for you each, and I'd like you each just to sort of give your top 2 to 3 key points that you feel are important in understanding how we can expand health equity through games and XR, including positives and negatives. So let's start with Cassandra Walker. Cassandra Walker is a Black queer licensed clinical social worker, trauma therapist, and founder of Intersections Center for Complex Healing, which is a practice focusing on the intersections of identity, trauma, and mental wellness. They also are a clinical contributor with Take This. So Cassie, I'd love to hear your perspective on this.
Absolutely. So yeah, I feel like when we talk about technology, we're not adequately talking through and thinking through the aspects of race and other forms of oppression across the identity spectrum. And so my biggest thing when we talk about tech is, how do we make sure that these things are not just codifying and hiding the racial discrepancies and gender discrepancies in the current healthcare system? And so whether we're talking about making therapy accessible and, telehealth and things, or we're talking about, physical health care and how to, increase people's access to really anything. The pandemic was like pulse oximeters and things, right? Those sorts of technologies don't work as well the more melanated you are. And so my biggest thing here is, how do we make sure that these technologies are actually helping and not just furthering white supremacist, um, you know, modes of care that currently are already the problem, and just ingraining them further? And how do we make sure that these technologies aren't being used to further the underpayment and exploitation of the actual healers and helpers and healthcare workers, which is something that we've also
Yeah.
seen with a lot of the bigger companies? And finally, how are we making sure that we're not continuing to cut out the people who are actually seeking help, and making sure that, technologies are coming for us, by us, and not, again, being given and passed down by and developed by people who don't actually understand us, whether us is trans folks, Black folks, Asian folks, or disabled folks.
Right. Excellent. Thank you so much. We'll come back to a lot of those points. There's a lot of food for thought. We're going to turn next, though, to Dr. Sarah Adler, who is a clinical psychologist and professor of psychiatry at Stanford Medical School. And Sarah is also the founder and CEO of Wave Life, which is a digital ecosystem dedicated to getting science-backed care into as many Gen Z pockets as possible. And I've got a couple sons who are Gen Z, so I'll have to make sure that they get those too. So Sarah, what are your thoughts on this?
Yeah, my thoughts are that we're sort of at this precipice. The digital health revolution started, many, many years ago, and we now have a ton of lessons on kind of what not to do, which really set us up and exactly the way Cassie was talking about, to really be able to do something very different and leverage technology in an incredibly exciting way. And when I think about leveraging technology, I primarily think about it from an access to care perspective. There are 550,000 licensed psychotherapists in the United States, and we have 90 million people who potentially need help. So there is a supply and demand imbalance that is we're not going to hire our way out of this with therapists or with psychologists. And so technology has this amazing ability to be leveraged as long as we are doing it ethically, responsibly, and with demonstrable, repeatable outcomes. So my sort of hope, and what I'm building out at Wave, and which very much is in line with what Cassie is talking about as well, is how do we sort of think about using very strong user-centered design with culturally humble, inclusive approaches, borrowing the stuff that we do know from science, but with being incredibly mindful that that science is coming from a white supremacy culture and trickling down. How do we combine all of that and also use data and build out investments in data infrastructure that allow us to make sure that we're getting the right care to the right people at the right time? This is ultimately a movable, measurable, sort of tangible thing we can do, but a lot of companies that are building are not actually investing in those data infrastructure that they need in order to demonstrate that we can do this ethically, responsibly, with cultural humility. So super exciting time, and also a lot of lessons that have been learned that we need to sort of make sure we're moving forward responsibly.
Yeah. And I think your top comments, I think, feed very nicely into our next guest, Dr. Olu Ajilore, who is at the Center for Depression and Resilience professor in the Department of Psychiatry at the University of Illinois, Chicago. And his lab currently is using computational neuroimaging techniques and digital biomarkers to better track and treat neuropsychiatric disorders. Dr. Ajilore serves as the director of the Mood and Anxiety Disorders program, and he's also the co-founder of KeyWise AI, which is a digital biomarker company. So, Olu, really happy to hear your thoughts.
Yeah, and thanks again for having me on this really interesting panel. And I agree with a lot of the things that the previous speakers, Sarah and Cassie, mentioned. And I think there's a lot of potential for technology to address a lot of the disparities that I see that Sarah talked about sort of at the national level, but I see as the director of a mood and anxiety disorders program where we have wait times of 8 to 12 months to see a therapist. Yeah. You mentioned the impact of the pandemic. Our wait lists have ballooned tremendously over the last 2.5 years. And I think, technology has a lot of potential to address some of these care gaps, which exist overall, right? About 45% of folks in the country with a mental illness actually get treatment for their mental illness. And those numbers are much worse for communities of color, Asian Americans. I think 23% of them with a mental illness actually get care, and it's like 33% for Black Americans. And so one of the ways that I think technology might be able to address that is by actually, with therapists extended with technology, what we're doing with telehealth. The pandemic erased a lot of the bureaucratic and unnecessary barriers to adopting telehealth. And when we were able to do that in our own institution, we were able to see, people who traditionally could not get here because of public transportation issues, financial issues, are able to make their appointments. We had a drastic reduction in no-show rates, much more adherence with making their appointments. And I think we're able to deliver better care as a result. And that's sort of one example of the benefits of technology. Another area where I think it can be useful is that we have a lot of bias in the way that we diagnose and treat patients in psychiatry. Unfortunately, we have a very checkered past with how psychiatrists have treated communities of color. Yeah. And there's a lot of prejudice and bias in the way we diagnose folks. For example, Black patients that present with both psychotic and mood symptoms are more likely to be diagnosed with schizophrenia than a mood disorder. And a lot of the misdiagnosis of depression in patients that are diagnosed with schizophrenia happen to be Black. And as a result, they're put on medications with much more side effects than necessary and have much worse outcomes as a result. And so if we can use technology to develop more objective ways of assessing our patients, of trying to come up with diagnoses that are more data-driven and less influenced by our bias, then I think technology has the potential to be really helpful. But we have to keep in mind what Cassie mentioned and making sure that we don't code in that bias, right, with our algorithms and with AI. And I think, going towards what has been mentioned before, I think if we come up with inclusive ways of developing the technology so that we involve, diverse set of stakeholders, I think we have less of a chance of that happening and having technology deliver solutions that work for all people.
Yeah, terrific. And I know within the context of the work that we do at Baycrest, our memory clinic, for example, switched almost to entirely virtual in the early days of pandemic. And again, in Canada, people may not know this, but about 90% of the entire population lives, within a few kilometers of the United States. But there are people who live further north and they don't have access to healthcare the same way. But the pandemic, through creating these sort of virtual medicine approaches, allowed people who normally would have to wait 6, 8, 10 months to be able to see a neurologist or a psychiatrist were able to get in much quicker and actually got much better care. But one of the issues is there's not always good internet connections, and so you need to make sure, if you're relying on, having people have to pay thousands of dollars to be able to access that care, then that's just putting another barrier in place. So, Cassie, I want to turn back to you. You raised a lot of really some significant and important concerns about the potential for technologies like games and XR to replicate flaws in our current healthcare systems rather than taking new approaches to address issues of health equity. And I wonder if you can share a little bit more about what those concerns are and what you and others on the panel think needs to be done to ensure that we are not just serving capitalism consumption, but also we're serving healing.
Yeah. So I think that one of the big things is especially as we're moving forward and we're talking about, Olu's talking about wanting to make sure that we're not coding these things in and being inclusive. I think we have to really understand how these systems of whiteness and colonialism work, and the fact that inclusivity is not enough, right? And we have to even look at, for instance, the DSM. We really need to consider getting rid of it. And I know that may be blasphemy for a lot of people listening, but I'm going to be a little spicy here. The DSM is trash, and it was adamantly never meant to be used for what we're using it for. The DSM is predominantly used for coding for insurance, and that is the exact thing that the originators of the manual specifically said it was not supposed to be for. And we've latched on to that and continue to use it in that way and continue to refuse to acknowledge the existence of the rest of the world in our diagnostics, which is to our detriment because we are now at best over a decade behind the rest of the world, particularly in the areas of complex trauma, because the DSM is also how funding decisions in the United States are made. And so as we're developing this technology, as we're looking at games for, there's games for ADHD that are being worked on, there's games for depression and all these things, but they're still using the DSM. They are still very white. They are still using methodologies that work for what they were designed for, which is capitalistic functioning, but actually end up being harmful to people who are targeted by our society's systems. Black people do not do as well with cognitive behavioral therapies. They do not do as Black women have ghastly outcomes with things like AA. And these differences then tend to get washed away in the technology discussion because it becomes about this idea of universalism. How do we make something work for everyone? Well, you don't. You just cannot. We should be looking at how do we make things that are adaptive and vibrant enough that they can be tweaked to fit most people. Right? Yeah. We need to stop buying into this universality spiel, which is incredibly toxic to difference and diversity and to health equity, and really acknowledge the fact that the discussions where we're so centered on how do we find objective, again, maybe we don't. Maybe we acknowledge that everything we do are going to be colored by who is doing it. And we move from that space of acknowledging that maybe we don't have to get rid of all of the difference. Maybe it's not about being objective. Maybe it's about seeing what we're actually doing, because technology has such a beautiful opportunity to do new things, right? When we talk about VR, the things that your brain does on VR is very similar to the things that your brain does during spiritual experience and during hypnosis. That could be so amazingly powerful, but we're still so wrapped up in this capitalistic system that keeps it away from the people who could benefit most. And we're so busy looking for universalism and objectivity that, frankly, I'm not sure even exists. That we're really kneecapping ourselves.
Yeah, really interesting points, because it's interesting because at the same time that everyone's talking about the need to move toward personalized medicine, some of these technologies are not taking us in that direction at all. I know, Sarah, you want to chime in, I think, on a related point. Yeah.
Definitely. I could not agree more with the spiciness of let's get rid of the DSM. And any taxonomy that we create is designed to narrow, to classify instead of expand, which is sort of the antithesis of what Cassie's talking about, which is the power of technology that we can do, is to use it to actually be more relational and experiential rather than folding into some universality or objectiveness. And I love that. I think this speaks very much to what I believe, which is fundamentally there are lots of kinds of data out there. We have objective data. We also have process data. We have emotional and relational data. We have our own sort of conceptual thinking. And we know that even a fabulous practitioner is never just following the manual, is never just following the rule book, or delivering the intervention from the book. The really brilliant clinicians are using their relationship, using those data that they're getting in the room with the person sitting in front of them, hopefully from a place of curiosity about the context of where this person is coming from, right? And at the same time, understanding their own context. That's what cultural humility is in the work. And I think that by holding ourselves to the DSM, we are not actually thinking about the transdiagnostic mechanisms that underlie all of these pathologies, right? And also even the inherent notion that the way we're reacting to our world or to a white supremacy culture is pathological in itself. Like thinking about things from a trauma-informed lens, the reality is most of us are reacting to the world in ways that the system is forcing us to react in, and these are adaptive things, and we've pathologized them and using the DSM. Where I think technology has an incredible opportunity in a few ways is not only to be able to go outside of that DSM taxonomy and collect far more data, lots of different kinds of data, the kind of data you can open your phone up to and that has its own issues, but there's so many different kinds and forms of data that you can use to then feed into predictive analytic, machine learning models that can then inform customization and personalization, to your point, Allison, about personalized medicine, which is so unbelievably exciting. And then hopefully Olu's work with biomarkers will come in and really kind of suss things out for us. But in the meantime, all of the sort of the things that we do every day, to Cassie's point, the way that we interact with the world, those data that we provide can be so powerful. The second place that just really, really excites me, and this goes exactly along with what Cassie was sort of speaking to, is the ability to be adaptive and the ability to actually give folks the right intervention at the right time when they need it. And that goes beyond the CBT protocol that we're delivering in this really boring app that no one likes and doesn't work for half the population. And since when does a response rate of 30 to 40% indicate really good care? Like, that's not that good of care. So how can we be adaptive, and how can we actually design experiences? And although I don't do as much with VR anymore, one of the things that we're working on is designing immersive video game-like experiences. Look, video games have 35-year history of how to keep people engaged. We should be learning from the video game industry. That's what we do, what we're building at Wave.
I was playing Space Invaders in bars way back.
Totally, without a doubt. I'm thinking more of the RPGs, the open world, the sort of the places rather than the sort of stimulus. But completely, you're totally right. Longer than that. And how can we borrow from what we know from this entire industry that has made a fortune out of engagement, and use that to bring things that we know meet people where they are. So for example, some of the things that we're building are these mini video game immersive experiences that are based in, we kind of don't really go the CBT route for the reasons that we're talking about, but more experiential routes, more relational, more acceptance and commitment therapy stuff, which has its own issues and is not super... It was not designed with the DEI lens in mind, but thinking about how do we co-design and adapt those things so they are referencing people's own experiences that they can bring to the table, and navigate through their own experiences to create behavioral change. So super excited about all those things. And yes, Cassie, let's get rid of the DSM.
Yeah, and I want to come back to the co-designing issue in a moment and the engagement issue, but I feel like I have to turn to Olu because as a professor in psychiatry,
I think I'm the only psychiatrist.
Is he spicy about the DSM? That's the first question. What are your thoughts?
Yeah. No, I have my own issues with the DSM, and I totally agree with all of the problems that have been brought up about it. But where I might differ from Cassie's point of view is that I think there are ways that we can use objective measures around some of the issues of the DSM. So, for example, in our work, we use how people type on their smartphones, right? Just basically how fast you type, whether you make mistakes when you type. And for me, that's a fairly objective thing. Now, there are all kinds of contextual things that go into it, and we try to take those things into account. But I think we can use those to get at some of those transdiagnostic constructs that Sarah alluded to that might be more relevant for actual functional outcomes, other clinical outcomes about how our patients are actually doing in their day-to-day life, especially when we're capturing behavior about their day-to-day life. And we're using that to inform what issues they might be having and how best we can give those adaptive, personalized types of interventions, especially when we're thinking about the fact that we're not trying to, when we take this data in our work, we're really trying to compare the person today to the person tomorrow. Everybody serves as their own baseline, and they're not compared to some kind of homogenized standard population, right? And by doing that, we can really tailor things for the individual. So I think there is a role for data in this process and addressing some of these issues.
Yeah, that was actually my next question. You sort of alluded to it, but I want to just ask it directly, because I think some people, when you said, well, obviously this is an objective thing, it'll work. I saw some eyebrows get raised from other panelists, and certainly, you're thinking, I think about, individuals we work with who are living with Parkinson's, might have a different way of typing, for example. Some people can't type if they got, rheumatoid arthritis. That's really quite serious. You can't move in the same way, or different people haven't learned to type in the same way. But I think what you're suggesting is that this kind of a measure isn't against some arbitrary random baseline. It's for each individual. So how do you make sure that things are really personalized that way?
Yeah, so the idea is that if you have those baseline conditions which may affect your typing, that gets taken into account how we analyze that data, because we're not comparing the person with our rheumatoid arthritis to somebody without, or somebody with Parkinson's to somebody without. And in fact, people can look at changes within the individual to see how that disease, which might be affecting their typing, is progressing, right? So we've done some work with collaborators looking at folks with neurological diseases, and how you type can track with the clinical status of your neurological disease.
Yeah. Cassie, I think you want to chime in, yeah?
Yeah, I just want to make sure that I'm clear here. I'm not saying that there's no place for data, right? I'm saying we need to be more critical about what data we are interested in, what are the questions we are asking, and how we're funding that data, thereby how we're directing it, right? Right now, what we have is a research environment that in the US that is hyper fixated on short-term treatments, short-term solutions. It's treatment focused. It's solution focused. It is how fast can we get you back to work, back to school, back to being a productive automaton, because we don't care about your humanity, right? Like, that's the problem. Whereas when you look at the research funding and the research coming out of, specifically a few spots in Northern Europe and Scandinavia, where they're doing amazing and very interesting work with voice hearers. And what are people finding the differences between mental health hallucinations and delusions and spiritual experience, right? Those kinds of questions could be fascinating and have so much important information and data that could be being utilized not only for treatment, but for actual depth healing, for how do we design a world that is actually accessible, right? How do we make these things work? And I think even, talking about the European example, when we come to research, even that for diagnostics, we have exploration in ways that outside of certain communities of color doesn't really exist in the mainstream. Things like the power threat meaning framework as a answer to less pathologizing diagnostics is a fascinating example that we just don't get to do here because of where our focus is and what we're using data for and what kinds of data and knowledge we are prioritizing and gatekeeping.
Yeah, it's interesting because, one of the things this reminds me of is the importance of integrating people's culture and background and spirituality into the healing. So in Saskatchewan, there is a hospital called All Nations Healing Hospital, which is run by the Feel Hills Qu'Appelle Tribal Council and the Touchwood Agency Tribal Council, and it's a combination. It has two different parts to it. So one is actually quite boxy looking. It's modern Western kinds of architecture, just square looking, with new MRI systems and all other kinds of modern Western medicine. And the other is very round and circular and has healing rooms and has traditional medicine rooms. And people can be going back and forth between the two. So it doesn't even necessarily have to be an either or, right? It could be a combination of the two. But they've designed the healthcare approach there in consultation with the people who are going to be using it to make sure that it's going to be something that they are wanting to make use of, and that it will, and I think they get the better results because of that. Sarah, I think you want to chime in on this point as well.
Yeah, I never want to miss the opportunity to lambast the payer system in the United States and how it leads capitalistically to all of these problems, including the ones that Cassie's describing in our research world, right? Is that the fact that the incentives amongst the stakeholders, the patients, even calling them patients, the people, and the commercial payers and the hospital systems, the providers are so misaligned financially that we have technology is our best hope to actually move the needle on getting care that is culturally informed, personalized, inclusive, and actually effective in any way. And the fact that these misaligned financial incentives exist make it just an uphill battle. And so I always look to, I mean, there are definitely problems with the Canadian system and Great Britain as well, but I look to these systems who have these single payer systems and look at all of those things that you can do because you are not stuck in the capitalism of it. So just any opportunity to lambast our payer system over here.
Happy. I'm appreciating the spiciness of this panel as a whole. Olu, I want to turn back to you and ask a question about personalization and also getting back to this issue of co-design, because that's come up a couple of times. How do you make sure that you're designing, back to Cassie's original point about, it's not universality. So how do you make sure you're doing co-design while still treating everyone as an individual? It's kind of, because you just ask every single person what they want, or how does it work, the co-design in the context of this personalized approach?
Yeah, I think it's difficult because you're balancing sort of somewhat competing forces. One of our projects was developing a problem-solving therapy coach that works on the Alexa platform, and we made sure that when we went through the formative design process, we included the kinds of patients that we treat here at the University of Illinois in Chicago, which is predominantly lower socioeconomic status and folks of color, Black and Latino patient population. And we had majority women, majority non-white in our sample that helped us design the application called Lumen. And we used their feedback in an iterative design process to make the communication with the device much more smooth and to reduce things like temporal load and cognitive load while working with it and improve some of the glitches. And this is all preliminary work, but we've shown that it actually reduces depressive symptoms, anxiety symptoms, and it worked really well, surprise, surprise, with women who were non-white, who had less than a college degree of education. But what's really interesting is that if you had low digital health literacy, you had much better outcomes, which is a little bit surprising. But we thought that maybe, we'll have to do a deeper dive, but that might have to do with less cynicism around the use of technology. But, sometimes people feel like when they're working with technology, they're not being judged in the same way they might be judged by a clinician that doesn't share their same cultural background. And in some ways, the technology has an advantage in that clinical interaction. If you'd rather, type something on a computer than deal with somebody who's, judging you or might be prejudicial towards you. Right. And there's some studies that suggest that there's a guy named Charles Jonasson who looked at outcomes on computerized cognitive behavioral therapy for their Black participants versus white participants, and showed that the Black participants did much better compared to the white participants. And they suggest that it's because they were comparing it to treatment as usual, and treatment as usual for the Black participants probably wasn't that good compared to the white participants. So I think, there's an example. So I think, to go back to your question, I think it's in that sense, we weren't coming up with a specific personalized type of therapy, but it suggests that the kind of people that are involved in the development of your intervention or your application are the very people that will benefit probably the most from it.
Yeah. Sarah, I think you want to chime in. I can see You're chomping at the bit there.
I was actually just thinking about what Olu was saying. Is I think that we have this something else that strikes me about sort of the power of predictive analytics and technology is we sort of look at care delivery as an acute phase situation where you have to be in distress, like based on the DSM. You have to be in trouble. You have to be causing a problem, not showing up to work. Again, back to what Cassie was saying about this problem-focused, solution-focused mentality. Instead of actually looking at mental health through as continual care over time, where we wax and wane over time. And I sort of talk about thinking about mental health as more similar to dental health, where we are doing the things every day that we need to do to brush our teeth. I know everyone on this call brushes their teeth and flosses multiple times a day like they're supposed to, but we do all of these things. We sort of need to learn how to do these things in order to prevent sort of downstream acuity. But because most care delivery models are only focused on acuity, we lose out. And I think the biggest lever that we have with technology right now is also in the community space. And that's something we haven't sort of talked about. But in terms of, again, cultural humility, and thinking about how do we actually leverage social media, technology, building communities that are literally the lifeline for underrepresented LGBTQ folks, BIPOC folk in areas where they cannot get acute care. This ability to leverage community through technology is incredibly powerful and sort of speaks to that ability to take care of your doing the things that you can do for yourself day after day after day in order to potentially prevent downstream acuity. Right. So wanted to throw that in really quickly.
Yeah. And the issue of prevention is really interesting because I think about, again, the work that we're doing in aging at the Rotman Research Institute and at Baycrest. We're interested in predictive neuroscience for precision aging is how we think of it. And really what that means is we want to be able to use data, but not just about what's happening in the brain, but about the whole person, about the environment, about everything, to be able to figure out for each individual what is the way to optimize their aging journey. And that includes preventing neurodegeneration in the first place. If you can't prevent it, how do you detect it as early as possible? Or how do you delay, progression? How do you treat people? How do you care for them if they're living in long-term care in a really personalized way? So we're thinking about it in those terms. And prevention is really huge. And one of the reasons I've really wanted to stress that in the work that we're doing is because I think about cancer, and I think about, when I was young playing Space Invaders in bars underage, way back in those days, people didn't want to say the word cancer out loud. They literally wouldn't even say the word, because it was, if you were diagnosed with any kind of cancer, it was viewed as a death sentence. It was also viewed that if your parents had it, you would get it, and sort of there was nothing you could do. And then science came along and said, here are some things. You may not be able to entirely prevent it, but there are things you can do to reduce its risk, right? And so we're looking at other areas like that. And it strikes me that games, the gaming approach, serious games and virtual reality, really immersion, may be really good tools for helping people, particularly, I think a lot of you are interested in issues of mental health and other areas that are in that space. It seems to me that there should be some way of being able to use these tools in the prevention space before we even have to worry about it. So I'm wondering if people think about that.
Well,
Cassie,
we already are, right? Like, people are doing that naturally. That's what's so interesting about all of this, right? Is we're trying to format things to DSM specification to get FDA approval and make it work the way the society that is exacerbating people's issues and causing some of them, making sure that it fits that, which interesting methodology. But regardless, what we see is when we look at studies in gaming, right, we do see people are using gaming as is to decrease stress, to cope, to build community.
Interesting.
For pros and cons, right? One of my colleagues, Rachel Cowart, is looking at how white supremacists are really succeeding in building community through games. Right. And so for better and for worse, that is happening already. I think the more apt question is how do we make sure that what is happening organically is leveraged properly.
Yes.
Right? We don't want to take it and shift it to the same focus that we already have that is not working. We want to see what's happening organically and take that information and that data to say, okay, so how do we get this to more people, right? When we talk about prevention from a mental health lens, housing, food security, right? Job security, access to healthcare, best prevention possible. So how do we use technology to bring about that revolution?
Yeah. And that leads exactly into, I think, what we're going to close with, because unfortunately we're just about out of time. I think we could go on for hours more. It's always so interesting talking to all of you. But what I'd like to do is just ask each of you sort of a quick round robin, your final statement. What would you each give as your top suggestion or two suggestions for how we can move games and XR forward in the ways that Cassie's talking about to be able to advance health equity? So Cassie, let's start with you.
Yeah, do the things we all talked about. Like if we want to do better with technology, we have to make the technology company workplaces better so that we're actually hiring properly and so that people aren't being harmed in the workplaces and then needing the technology they're trying to build, right? So yeah,
do what we say. Good.
be more open to thinking more creatively and outside the box of what we already have.
Be spicy, be open, and listen. I think that's what I'm hearing. Okay. Sarah, your thoughts?
Yeah, I think, and I hate to jump on Olu's, what I know he wants to go to too, but co-design with your users and with your end users 100%, and use data, not necessarily just objective data, but gold standard measures that align with DSM. Those are useful to validate against. Those are useful to sort of move us in the right direction to validate new and better measures for personalization. But use data to demonstrate outcomes. And when I say outcomes, I don't mean symptom reduction in depression, stress, anxiety. I mean quality of life metrics. Yeah. How is this person existing in the world? And acknowledging, to Cassie's point, that again, I think really importantly, that no matter how much we do in terms of prevention, there are societal systemic structures that it's not just about doing your mindfulness exercise every single day. This is about making sure folks have financial literacy, making sure that folks start off from an equitable playing field where they have the same opportunities regardless of where they come from. So
great.
But we can definitely use lots and lots of data to sort of highlight, mirror, and support those better outcomes.
Super. And Olu, last minute for you.
Yeah, so I think if we can use technology to allow people to have ownership over their own health, their own mental health, I think that would go a long way, so that it's not yoked by any kind of system or tied down to sort of traditional medicine that's more paternalistic and authoritarian, but it's more democratic, for lack of a better term. And then people, I think that will go a long way therapeutically as well if people feel like they have control over their mental wellness, and have this sort of maintenance and prevention approach that kind of Sarah was talking about, rather than only coming in during moments of crisis or only coming in when things are at their worst, but that they can prevent that from happening by taking ownership over their own health.
Terrific. Thank you all so much for this interesting conversation. I think that if the designers out there, the game designers and XR designers are listening to you, I think that maybe there is hope that we can be using these technologies to break down those barriers and use XR in gaming for increasing health equity. Thank you to Cassandra Walker, Sarah Adler, and Olu Ajilore for joining us. Thanks very much.
Thank you.
Thank you.
Thank you.